Thank you, ma'am. Good morning, and thank you for being with us today. I will be talking to you briefly over the next 10 minutes on the technique and pearls for deep anterior lamellar keratoplasty, basically for beginners. So I think I'll skip through all the theoretical sections. Most of these have been well covered by all the earlier speakers. So deep anterior lamellar keratoplasty is a technique which bares the Descemet's membrane and gives you a maximal depth lamellar keratoplasty surgery compared to all the other manual techniques. So when does one recommend a deep anterior lamellar keratoplasty? In all those cases where the endothelium is absolutely normal and there is no posterior stromal, there's no scarring deeper to the Descemet's membrane. It has its own inherent advantages that the recipient endothelium is retained. Descemet's membrane is integral to the corneal tectonic strength. The complications of an intraocular surgery are all removed. Postoperative immunosuppression is less, so less chances of a rejection, though of course now DALK is not said to be foolproof to rejections as well. And let's now move on to how exactly you would go about, or how will a learner approach deep anterior lamellar keratoplasties. There are no shortcuts to learning or perfecting a surgical technique. Optimal training, both self-learning and supervised learning, will remain the keystone in mastering any surgical technique in ophthalmology. Understanding the preoperative considerations in deep anterior lamellar keratoplasty, one has to realize when will a big bubble technique work, when you will have to adopt the other kind of techniques, when you will have to go on and do a manual technique. So it is always important that one perfects the technique or learning a manual lamellar keratoplasty so that in the inadvertent case of a perforation or a need to convert from a big bubble to a manual, you're still able to successfully complete the surgery without having to convert it into a full thickness penetrating keratoplasty. Again, it is important to understand that the preoperative corneal thickness plays an important role. The extent and area of the corneal thinning is also important in deciding how you're going to introduce your needle, how you will be able to achieve the big bubble, or make an initial decision that a big bubble will not work in cases where your corneal thinning is significant and you'll have to achieve your deep anterior lamellar using a manual technique. The intraoperative considerations I will be telling you along with the surgery, and of course the postoperative management is as important as well, because you could still have perforations along the suture tracts in an uneventful deep anterior lamellar keratoplasty and find a shallow or a collapsed anterior chamber in a perfectly uneventful surgery as well. So in deep anterior lamellar keratoplasty can be actually done for optical purposes, could be for therapeutic purposes, could be for tectonic purposes. The common indication, as all we know for optical DALK, will be a keratoconus, stromal dystrophies, degenerations. For beginners, it's fairly easy to start with dystrophies which are not involving your deeper stroma and move on and do those keratoconus where you do not have extensive thinning. And of course, therapeutic, when you're dealing with descemetocele procedures, the technique has to be done. It's slightly different and you cannot achieve a big bubble in most of these, and you'll have to either resort to a layer by layer manual delamination or a viscoelastic aided dissection as well. So these are the various techniques which are available for DALKs, but by and large, most of us still adopt to doing the inverse big bubble technique or the layer by layer manual dissection, depending upon the preoperative indication of the case. What is important is, as in any penetrating keratoplasty, in DALK also you need a proper centration. A trephination, nowadays we have a preset trephine depth, and you do trephine to up to 60 to 70% of the initial depth and remove the anterior lamella to help you to visualize the exact place where you're placing your needle. We now have very sophisticated systems of intraoperative aided OCT, which helps you to assess where exactly you're passing your needle, and this perhaps will simplify, but of course it's more sophisticated and it's not cost effective in most of the procedures, most of the places. The anterior lamellar dissection, if you're a beginner, is best done before you place your bubble, because if you do an anterior lamellar dissection after you achieved a big bubble, and if you're a learner, you would spend more time doing the lamellar dissection, and this could lead to an inadvertent Ured-Zeverlia syndrome as well. So if you follow all the initial techniques properly, you would be able to successfully bear the Descemet's membrane. Another important pearl which you need to know is, remember, is always perform a anterior chamber paracentesis when you're doing the surgery before you achieve your bubble. This softens the anterior chamber and gives space for the bubble to expand into the anterior chamber when you are performing the big bubble technique. Of course, suturing has its own, suturing has to be done perfectly well, and your postoperative and investigations in terms of anterior segment OCT and other relevant ones as well are important. Just a brief mention of what the Duval's layer is. The pre-descemetic posterior stroma, which tends to behave differently to this bubble injections, which we have now observed, considering the fact we have moved to doing more and more of lamellar surgeries and less of penetrating keratoplasty surgeries. The type 1 bubble is when the bubble is achieved between the Duval's layer, a small posterior layer of the Duval's layer is left behind, and the remaining part is bubbled out. And the type 2 is the true Descemet's bearing, where you bear the Descemet's entirely from the rest of the stroma as well, and you can have the mixed depth as well. I think the scope of this course does not take us into how we would define or how we would look at it, but probably in subsequent surgery, which I will be showing, you will be able to make out the Duval's layer as well. Again, tips for a successful DALT surgery could be a repetition of what I told you earlier: a good preoperative case selection, a good technique which will be apt for the case which you have selected, improve access to Descemet's membrane by properly barring with the air injection. Here you're seeing the small bubble test, or the double bubble test as it was subsequently described as well. You've seen the bubble is achieved is properly achieved, and it has pushed out all the smaller bubbles to the periphery to show that that we are in the correct plane and we've achieved the bubble well. And so this could also, doing the small bubble test or double bubble test is good for beginners if you're doing DALTs for cases where your posterior stromal bed is not clear enough and it's not keratoconus and you're performing for other opacities and you're not able to visualize. This is another technique which helps to tell you that you're exactly in the correct plane and what you're doing is right. As in this case, I am removing the anterior lamellar after I've achieved the big bubble, but as beginners, I would strongly advise not to do that. Otherwise, there have been inadvertent cases of Uretzavella syndromes. The anterior lamellar is being removed out. You see how thin the anterior lamella itself is, as this is a case of keratoconus. And this is a step which all of us are always glad. It's called the brave slash, where you want to de-roof your big bubble, and you're always worried that you might, when you're de-roofing, inadvertently damage the Descemet's membrane as well. In such a case, you could always opt, as I've done in this, is you could de-bubble or remove the bubble through a side entry and mark that entry beforehand and inject viscoelastic through the entry so that you're safe enough when you're separating the residual stroma as well. Some people also trying to mark the point where they're going to give the brave splash and plug it in initially with a thick viscoelastic device, viscoelastic, so that when the air is bubbling out, you still will not, your tip of your needle is not going to go in. Again, do not hesitate when you're making cuts. It should be one stroke, and that brave slash helps you to achieve this well. As you could see, the Descemet's membrane has been completely bared, and you can see the bubbles and the AC, and we know we have achieved what we wanted to do well. And most of these cases we do use non-therapeutic or non-optical grade cornea, so that is why the stromal haze is there, which usually clears away in your first post-operative period. So knowing your bubbles, knowing which layer you have bubbled, whether it's a type 1 or a type 2, helps you to know whether you have to still remove the Duval's layer and go in further to achieve a complete Descemet's bearing. I think I'll skip all the other theory involved so that we could see a few more surgeries before I would close down. And these are again surgeries for keratoconus, DALT performed for post-LASIK keratectasias. Sometimes, initially we used to make a small track using a cressetinide, which I no longer do, and you could use a simple bent 30 gauge needle put onto your syringe, or you have specialized cannulas also, which help you to achieve your bubbling in a very effective manner. And precept trephines are now available, which helps you to set your trephines to a pre-desired depth depending upon the preoperative pachymetry in these patients. These are available with the Moria microkeratome, Moria systems. I have no financial interest, but they do help to make your surgery easier. Some of us use the Hesberg's Barren Strafine itself, and we plan preoperatively the number of turns we'll achieve so that we get to the pre-designed depth. And this is very important so that your cut is perfectly perpendicular and helps you to achieve a good dissection of the stromal layers when you're removing them out. But I think nowadays more and more surgeons are really not worried, and they do tend to leave a layer of the stromal lamella at the periphery, because inadvertent perforations do occur when you're trying to trim out the stroma perfectly out and at the graft host junction. I think I've almost completed my time, so I'll just shortly touch upon therapeutic darks as well. This is how your postoperative period, postoperative pictures look like, and you achieve a very good interface and with minimal scarring, and the effect is quite phenomenal in these cases. Of course, you do have postoperative considerations, which I think, and difficult cases, which Rishi will be covering shortly. So just a quick look at how we are doing therapeutic darks or darks done for desmatoseals. These are technically more difficult. You have to be a little more experienced before you delve into doing these. Remember, you cannot refine, and you probably will have to make only a trephination mark and then complete your circumferential incision using a blade, and very gentle dissections to achieve a Desmet's bearing. As you would see in both of these cases, my video stops short because I perforated after almost a 99% complete removal, when I was trying to remove a small stromal ledge right at the edge. So both of these cases, my surgery would stop short because I had to convert it into a penetrating keratoplasty. This was in my initial learning curves when I was doing them for therapeutic purposes as well. So I think with this, I will shut down, and I thank ma'am for the opportunity to speak in this course, and let Rishi deal with you on all the advanced scenarios. Thank you.